Okay, so hey everyone. We are now going to go through disorders of emotion. Um, just gonna slideshow it. Yeah, great. So we'll go through an introduction, discuss what feelings are, what emotions are, affect, things like that. And then we'll discuss normal emotional reactions. We'll discuss abnormal emotional reactions. We'll discuss abnormal expressions of emotions. We'll discuss morbid expressions of emotions and then highlight a little bit on the disorders of emotion. So when we say morbid disorders of emotion, we're talking now of the actual syndromes, the diagnoses, things like that. So we need to differentiate between feelings and emotions, even though in regular speech we use them interchangeably, okay? So a feeling can be a positive or a negative reaction to the experience or of something, an event, a situation, a scenario, etc., etc. A feeling is subjective, very subjective, and it is the experiential aspect of emotion. So what you experience is a feeling, okay? The emotion in itself now is the stirred up state, all right, caused by physiological changes in the body in reaction or in response to an event, a situation, etc., etc. Okay, an emotion in itself tends to either maintain, as in keep, or abolish the causative agent. So the causative agent is now the event or the situation. So um, let's use an example of something positive. So it's your wedding, or it's your sister's wedding, or something like that. And you're happy, right? So ila emotion is what maintains that happiness. The reaction, the feeling is that happiness. The emotion can also be happiness, but it's really what you do to keep that happiness, kind of at that level where you want it to be maintained. So the physiological changes that are associated, which now becomes the emotion, is your serotonin levels rise, your dopamine levels can rise as well, stuff like that. And the opposite being for, if you're sad, different changes as well for anger, irritability, and stuff like that. Okay, anxiousness as well. All right, mood. We've discussed this a little bit in class the other time. Mood is a pervasive, meaning over time, over a spectrum, and sustained emotion, right? So we're talking about things like intensity of the emotion. We're talking about duration of the mood. We're talking about fluctuations as well in mood. So you could be sad, yes, but you could still, laugh at a joke, or you could be happy, but you could still, feel sad, or empathy in terms of like sadness for somebody's situation, which is a sad situation. Those are the fluctuations we're talking about. So it's normal to have those fluctuations because mood occurs on a spectrum, on a continuum. Okay. Affect, as we discussed last time, is the motor aspect of mood, which is now showing said mood, showing said emotions, the expression of emotions. Okay. So we kind of get confused a little when we talk of emotions in the context of medicine, particularly in psychiatry, because people tend to use terms like depression, anxiety as regular English words, but they have a very different meaning. Well, not very different, but they do have a different meaning in psychiatry, especially when we talk about normal emotional reactions on a daily basis. So sometimes it can be difficult to actually distinguish, is it a true disorder that we're dealing with here in terms of the patient? For example, is it really a generalized anxiety disorder, or a phobia, or a social anxiety? Is it a major depressive disorder, a major depressive episode, or is it sadness and is it worry, which are normal emotional reactions? Now, this has some serious implications because some we can actually miss the people who truly have the disorders and require management. And instead, we kind of, get caught up kwenye biases zetu based on language and inferences that are language related, and we kind of like just put them in the category of they're just using the term as a normal English word, which is where social media kind of comes into play currently. You find people very loosely using terms and that are diagnostic terms like autism or I'm so ADHD. But are you really? Or, oh my God, I have an OCD for this particular thing. You're taking away from someone who actually has an autism spectrum disorder and requires help. You're taking away from someone who actually truly has ADHD as a diagnosis, who truly has obsessive compulsive disorder, an anxiety disorder, a major depressive illness, okay? So as medical personnel then, you have to learn how to differentiate and ask further questions in your psychiatric interview to elicit, is it really a disorder I'm dealing with, or are these just symptoms that are suboptimal, subthreshold symptoms of a disorder, or this person doesn't have a disorder at all, that what they're experiencing is maybe grief, which is a normal emotional reaction or normal response to the particular situation they've told me about, and not really a depression or an anxiety, etc., etc. Okay, and then you go a step further and educate people on that, because that is ethically part of your job. Okay, moving on to normal emotional reactions. So some emotional reactions are normal to the events, okay, in which they are experienced. For example, a grief reaction. If you lose someone or you lose something, you lost a job, you grieve that. You receive a diagnosis of a chronic illness. For example, people who've been diagnosed with diabetes, people diagnosed with HIV, can kind of find it difficult to express themselves, or may have a feeling of sadness, which is normal to experience with that situation. Some patients, while experiencing certain symptoms, can also have difficulties with their emotions and their emotional reactions. So there are hallucinations that are quite frightening. There are other psychotic symptoms that are related to speech, that are related to certain behaviors that can make the patient or the individual feel sad, or they may feel irritable. Patients experiencing hallucinations that are positive in nature, patients in a manic episode, for example, experiencing the voice of God talking to them, or the angels are singing in their ears, so they would obviously feel happy. It's a positive experience. Sometimes it can be hard to distinguish between some normal emotional reactions, particularly grief and major depressive disorder. So take-home reading for this particular class is to read about the difference between major depressive disorder and grief, okay? When we're discussing normal emotional reactions, it's very important to distinguish aspects of functional capacity. So, for example, a major depressive episode can present with difficulty in daily functioning. So you can have difficulty in social, occupational, and other important areas of functioning, versus while grief may impair functioning, it's not at a level that is similar to a major depressive illness. Similarly, worry and fear versus anxiety. For example, children have normal fears for their particular age sets. When they're starting to go to school, especially now, they start going pretty early with daycare and stuff, age 2. Most children are actually in daycare. So they can have a separation anxiety. But if it impairs their functioning as children, they're unable to sit in class, they're crying, they're just having emotional reactions that are out of proportion to what is expected for separation anxiety at that stage, then it stops being separation anxiety. And then we can start thinking this may be a separation anxiety disorder, okay? Irrational fears like phobia, for example. At a certain age, you may be afraid of the dark, or you may be afraid of needles, but as you get older, you're expected to at least emotionally be able to deal with that worry or that fear associated with that. But if you're unable to, and it really interferes with a particular situation or your functioning, then we're starting to say this is an anxiety disorder and not in the realms of normal worry and fear. Okay, so again, distinguishing those words is very, very important in terms of management, because you need to make a diagnosis with a certain level, certain degree of certainty. Sometimes you don't really need a diagnosis in order to treat the particular individual, but then you don't want to miss the diagnosis. You don't want to miss the disorder, right? Abnormal emotional reactions are emotional states that are understandable in the context of stressful events, but they're associated with a prolonged impairment of functioning. So it's something we we talk about in terms of adjustment disorders, right? We'll do adjustment disorders in detail later on during the module. But for example, people who received a diagnosis of HIV, we've had a few patients who received a diagnosis of HIV, and their reaction to, getting out of the doctor's office or the counselor's office is to attempt to kill themselves. We've had patients who've had breakups relationship-wise, and they've, attempted to end their lives. So this type of reaction is actually beyond a normal reaction, okay? So when we talk about it in terms of impairment in functioning, patients who've received a diagnosis of a chronic illness, for example, have gone through a breakup, they may complain that, so while the suicide part is a little on the extreme side of the spectrum, they may actually hear in abnormal emotional reactions complain of, I'm having difficulty eating, I'm having difficulty sleeping, I can't concentrate very well, things like that. Anxiety disorders fit under the realm of abnormal emotional reactions, or category of abnormal emotional reactions. A panic attack sometimes can be a response, an emotional response. Panic attack is not a diagnosis of an anxiety disorder. Anyone can have a panic attack. We'll discuss panic attacks, generalized anxiety disorders, phobias, and MDD in detail later on, okay? And then when we talk of abnormal expressions of emotions now is when we, when I highlighted on, receiving a diagnosis and trying to end your life as an almost immediate thing, or having a breakup, and then trying to end your life and that sort of thing. So they're emotional expressions that are very different from the average normal reaction that you would expect, but the patient is aware of that expression of emotion. So it's important to be very culturally competent here and really know what is acceptable in certain cultures. For example, in certain cultures where a person has received news of a death, falling down, and fainting, it's not really syncope, it's more of a conversion really, is considered normal. So you don't really find people gasping like, oh my god, we need to intervene, like we need to check their glucose levels, etc., etc. But in other more Western cultures, people seeing that may be like, okay, what is going on? Is she in shock? Do we need to resuscitate them with IV fluids and stuff like that? So it may be an exaggerated response, like the suicide attempts that we discussed, or the falling, or that sort of thing. However, it can be the complete opposite of that on the other end of the spectrum, whereby there's a complete lack of emotional response. Excuse me. If you've come across some people where they're informed of a death or their own diagnosis or that sort of thing, they may not respond emotionally almost at all, which is not something that's normal. Okay. So there's something we call a label indifference. I'm pronouncing it in English, that's a French word, which is a dissociation of affect, really. Sometimes patients with chronic illnesses may not necessarily, they may seem like they don't really care about how the diagnosis affects them or how their diagnosis affects the people around them, okay? And then some people can experience depersonalization and derealization, which we discussed at length last time. We've got patients with severe major depressive disorder who can experience a complete opposite, and they can be smiling throughout, the illness. So it's more atypical in nature. And then when we discuss morbid expressions of emotions, here usually the patient is unaware of the morbidity in their emotional expression, which is different from what we just saw, whereby the patient is aware of that abnormal expression in their emotions. So sometimes we can see an inadequacy and incongruity of affect with the mood. Like we've discussed in class, a patient can be saying, I'm so sad, with that big smile on their face, or it can be an inappropriate kind of affect. It doesn't really tally with the mood. It doesn't really tally with the emotions. It can be seen in schizophrenia as well, and other psychotic disorders, and this is what we call parathymia. Sometimes patients can have a blunting or flattening of affect as a direct expression in relation to the diagnosis, the underlying illness, or sometimes we can see a blunting or flattening of affect in relation to some medications that we prescribe. A blunting or flattening of affect is restriction of emotional expression, right? So you've got a complete, like, no expression versus you've got some restrictions. So it's up to you in your reading to read and figure out which one is a restriction and which one is a complete cessation of emotional expression, motor emotional expression, right? And then we've got a lability of affect, which can be seen in mixed affective states, where it's very easy for the patient to switch between one emotional state and another. So 1 minute, and it's not part of that normal healthy fluctuation that we see with daily conversation or, like, daily interaction. So 1 minute patient is irritable, very angry, and then the next minute, out of nowhere, they're laughing and giggling, and, like, it's just doesn't really add up, or they're in tears, they're crying all over the place. Morbid disorders of emotion include the pathological states that we've discussed, sometimes that are triggered by stressors, like we talked about death of a family member, loss of a job, et cetera, that can resolve when the stressor is removed. Okay, so we've had patients with a diagnosis of a bipolar disorder who have hypomanic or manic episodes during exam time, which is a stressor. And once you deal with that and you up their dose for their mood stabilizer, or whatever they're on, really therapy gets intensive around that time as well, and exams are done, they go back to that state. Similarly with adjustment disorders as well, in the presence of a stressor, if you removed that stressor, for most people they usually go back to baseline. However, some states may not necessarily resolve when the stressor is removed and can actually lead to further episodes. So depressive disorders, for example, the initial very first depressive illness, the MDD that you're making a diagnosis of, can be in relation to a stressor. And once you deal with the stressor, you may find that it still puts the patient at risk for another depressive episode with or without a precipitating event. Yeah. Similarly, bipolar and related disorders, we've had patients where this lady, her first episode of mania was sparked by the death of her father, but then she went on to have other manic and hypomanic episodes with no stressors, no precipitating factors. Anxiety disorders as well are similar to that, particularly with generalized anxiety disorder. Sometimes we can have morbid expressions of emotions due to organic lesions, for example, frontotemporal dementia, which we'll look at in detail later on, or lesions of the temporal lobe, for example, in epilepsy, because remember, emotions are processed in the temporal lobe, particularly the limbic system. So when you've got a lesion in the limbic system there, due to one reason or another, trauma, tumors, neurocognitive disorders, drugs, medications that affect circuitry, biochemistry around there, you can also have morbid disorders of emotion. So don't forget to read the chapter. That's pretty much it. Yep. Thank you.